Welcome. I'm delighted to see you all here for the 17th annual McCabe Lecture, and the second one of which we're holding on our Garnet Homecoming and Family Weekend. The McCabe Annual Lecture is an annual event that brings a speaker to campus who is distinguished in his or her career. The series was dedicated as a memorial to Thomas McCabe, class of 1915, who was a leader on the athletic field, in business, and in politics. Swarthmore is fortunate to have been the beneficiary of his extraordinary generosity through the McCabe Library, the Scott Amphitheater, and over 250 wonderful students who, over the years, have been the recipients of the McCabe Scholarships. One of these students is Jennifer Johnson, class of 2012. Jen is the president this year of the McCabe Scholars. She is a senior from Corvallis, Oregon. Jen is an honors linguistic major with an honors minor in sociology and anthropology. She is also a member of the women's cross country and track and field teams. She currently works in Professor David Harrison's Endangered Languages Lab, and this summer worked with the Confederated Tribes of the Siletz Indians on the revitalization of Siletz Dene. She is an active travel contributor to the Phoenix, Swarthmore's student newspaper, encouraging her fellow students to get out and learn about all the cultures in Philadelphia. Please welcome Jen Johnson, who will introduce the McCabe Lecturer for this year.
Thank you, Dr. Chop. Today, Swarthmore College and the McCabe Scholars Society are honored to welcome Rear Admiral Dr. Ann Schuchat back to campus to deliver the 17th Thomas B. McCabe Memorial Lecture. Mr. McCabe is most remembered for his pivotal role as the director of the Scott Paper Company, which grew under his stewardship from a small one-mill plant in Chester to one of the world's largest paper producers. From his office at Scott, he remained involved with the college and served as a mentor for many students throughout his life. 2 years before his death in 1982, Mr. McCabe received the Ernest T. Stewart Award for Alumni Service from the Council for the Advancement and Support of Education. His legacy has marked our campus and our students, and we are grateful. Each year, the Thomas B. McCabe Memorial Lecture welcomes an individual with a distinguished career in public service, business, government, education, or medicine to speak to the college. It has often been an alumnus. This time, for the second time ever, and for the second time in so many years, it is an alumna. This is also the second time in history of the lectureship that the speaker has come from the medical field. The last medical professional to deliver the lecture was Frank A. Oski, class of 1954, physician and chief pediatrician at the Children's Medical and Surgical Center of Johns Hopkins University in 1988. Since she graduated with highest honors in biology in 1980, Dr. Ann Schuchat has had a distinguished career in the medical field. Many moviegoers around the world now know her, if not her name, then at least the idea of her personage, as the Kate Winslet character in the recent blockbuster Contagion. Had Dr. Schuchat fallen ill or been called away on short notice to address a public health crisis, we would have had Kate Winslet come and give the speech in her place. Lucky for you, both Dr. Schuchat and the rest of the world are well enough today that the Genuine article can be here to deliver the speech. Best known to a general audience in her role as the Assistant Surgeon General and Director of the National Center for Immunization and Respiratory Diseases, Dr. Schuchat's work puts research and theory into policy in practice. She testified before Congress as the Center for Disease Control and Prevention's Chief Health Officer during the H1N1 pandemic response in 2009, and also served as the CDC's interim deputy director during that time. Since she began her career as an epidemic intelligence service officer, she has made significant contributions to infectious disease prevention through research, surveillance, and policy, developing guidelines and disease monitoring systems. Outside of the United States, she has worked in West Africa on meningitis and pneumonia vaccine studies, in South Africa on surveillance and prevention projects, and in China on SARS emergency response. Since graduating with honors from Dartmouth Medical School and completing her residency at New York University's Manhattan VA Hospital, she has also co-authored more than 180 scientific articles and reports, been elected to the Institute of Medicine, and been honored with the Public Health Service's Meritorious Service Medal. In 2010, she received her second star as a Rear Admiral of the United States Navy. The last time Dr. Schuchat spoke at the college was 6 years ago, when she addressed the class of 2005 at commencement, when she received her honorary doctorate of science. Her parting homily for the graduates was, "The world is small, the problems are big, but there are solutions everywhere." Her work exemplifies this wisdom. On behalf of Swarthmore College and the McCabe Scholars Society, I would like to thank the Rear Admiral, Dr. Ann Schuchat, for her service to the United States and the world in the field of public health, and to wish her all the best for a long and satisfying career. It is my honor to welcome her to the stage at this time.
Well, thanks, Jen. And if I wasn't feeling pressure before, now that I know I'm standing between you and Kate Winslet, I'm really not ready to give this talk. I really want to thank Swarthmore and the McCabe family for the chance to be here. I'm having a day flooded with nostalgia. I've run into some classmates and professors and got to meet with some of the students over lunch, and it's really such an extraordinary place, and you are such extraordinary people that I kind of would like a random person to come up here instead of me to address you. But I'm really passionate about this topic and am looking forward to hearing your comments and questions and having a chance to discuss things. Now, there are a couple people who were here in the 70s with me, and they can attest that I was a contender for least likely to return to Swarthmore in a uniform. You know who you are, and it's pretty surprising to me as well. This is not a military uniform. This is a non-military uniform of the Commissioned Corps of the U.S. Public Health Service. You may have heard of Surgeon General Everett Koop, and when he was Surgeon General, he brought back the uniform, and more recently, in leadership positions, it's become a daily thing for us. Now, you also heard from Jen that there haven't been that many women McCabe scholars, and in fact, or McCabe lecturers. And your lecturer last year, I heard, was fantastic, the editor of Glamour magazine. So now imagine my dilemma, trying to decide what to wear today. I was grateful that I have a morning ritual that's fairly simple. I do need to make one amendment to the introduction. At Swarthmore, I was an honors student, but I actually majored in philosophy and minored in biology. And so my Swarthmore years weren't just not uniform, but they were also filled with days and nights thinking about truth and justice and beauty and all that you study when you study philosophy intensely. And so it's perhaps a different direction that I'm going to take in my talk today, rather than give you sort of the latest public health story, to think about truth and justice and a little bit of beauty in terms of the public health mission and challenges that we face today. But I also, I'm back at Swarthmore, I'm feeling competitive, and I needed to give you a little bit of my own credentials and say, I was in vogue, okay? So I don't know, the people in the front can see that the first words in this article in the fashion issue, the September issue of Vogue 2009, are my name. But the people in the back and even the people in upstairs can see a few other things about this. So what I need to say is that this is a daily reminder that in public health, it's not about me. It's about families and communities and what difference we can make for them. And it's really a wonderful field for any of you who are kind of on the fence about how you want to spend your life. And what I'd like to do in the next little bit of time is share with you the incredible story of vaccines and immunization, where they've gotten to in the US and around the world, and some of the challenges that we're facing today. I want to start with Paul Ehrlich, who was a Nobel Prize recipient for his work finding the first cure for syphilis. It wasn't a perfect cure, but it was the best of its time. But he also is the origin of the term magic bullet. And the idea was a magic bullet was something that would attack the diseased tissue and leave the healthy tissue okay. And there probably is nothing in medicine and science that fills the definition of a magic bullet as much as a vaccine. There probably is no disease ever that had so much interest in a magic bullet as polio. And so I want to start the story today with the story of polio. When I was in college, I didn't know this, but now I do. President Franklin Delano Roosevelt himself was paralyzed from polio as a young man. I think I knew he had polio, but I hadn't realized he'd been paralyzed because that wasn't a very public part of his legacy. But he and colleagues developed something called the National Foundation for Infantile Paralysis, which then became the March of Dimes and was really a national movement to find a cure and then a prevention for polio. There's a fantastic book about the story of polio called Polio, An American Story by David Oshinsky. But on the top left of this, you can see the iron lungs. I don't know if we have anyone in this audience, but I've met nurses who talk about the horror of taking care of children trapped in these iron lungs, awake, alert, unable to breathe without the mechanical force of the iron lung, and really looking at a pretty dismal, difficult future. The bottom left picture in this slide shows the polio pioneers. Again, sometimes when I'm speaking, there's a polio pioneer in the audience, so if there's any out there, let me know. But these people were in the first, is that, yeah, oh, excellent, yeah. So you can talk to her later about what it was like. But polio pioneers were in first, now I'm gonna get you in trouble by giving your age, but they were in first and second grade in 1954 when the Salk polio vaccine was used in the largest medical experiment ever in the United States to test a new vaccine. And basically, the vaccine worked, and it was immediately shipped around the country and began this incredible transformation from a disease that used to paralyze about 1,000 people a day to a disease that this past year left less than 1,000 people paralyzed. So a really incredible story. When I was here at Swarthmore, another incredible story was happening. Far away from here in West Africa and in south of Asia, mass vaccinations against smallpox were happening. And this particular virus, this disease that had really been a plague against humanity for millennia, was eradicated. No one anywhere has gotten smallpox naturally since this eradication effort was successful. The ultimate social justice, the ultimate equity, that everyone, everywhere, forever is protected against this disease. And that really gives you the power of vaccines and the power of immunizations, because you can't do this without a massive, intentional, collective effort. The vaccine, the discovery, the science, the medical breakthrough, that's important. But the human and social commitment to use that vaccine to immunize, and for an eradication initiative to immunize everywhere, is really extraordinary. The 20th century saw incredible progress in reduction of vaccine-preventable diseases here in the United States. And this slide shows you how much disease there was before we routinely vaccinated, and then what has happened in the era of routine vaccination. Smallpox, of course, we don't even have to vaccinate against anymore because we've eradicated that virus. But most of the diseases you see here are at about 99 or 100% reduction before the vaccine era. Now, I want to mention mumps. You all may know that there are some outbreaks on college campuses around the country of mumps. It's a very uncomfortable disease to get when you're in college. It's a little easier to get when you're a young child. But in general, we're making a huge difference in these vaccine-preventable diseases. And these aren't all of them. Since I graduated from medical school in 1984, the world of routine vaccination has been completely transformed. We've gone from 7 diseases that we could routinely vaccinate against to 16 diseases that children are routinely protected from. They range from diseases that are common acute febrile illnesses to cancer. diseases like the cancers that hepatitis B and human papillomavirus can cause. So it's really been an extraordinary story. And the vaccines have been like magic. We've had a huge impact on the diseases that these vaccines prevent against. This slide of the impact of vaccination against hepatitis B shows that we not only reduce disease, but we practically have eliminated the racial and ethnic disparity that used to occur with this disease. The very high rates among American Indians and Alaska Native children, and the very high rates among the Asian population. So vaccines, in many ways, can be the great equalizer. I know over lunch I learned there's a climate action committee here, and this is my obligatory global warming slide. It's not actually temperature, but it's showing you the incidence of hepatitis A in the US, and you can see enormous geographic disparity between the western states and the eastern states. But once we started vaccinating in the western states initially, we've essentially wiped out that disease from the whole landscape. Another vaccine is targeted against the pneumococcal infection. These are serious infections of the lungs, the blood, and the cerebrospinal fluid. In 2000, a new vaccine that targeted 7 different types of pneumococcus was licensed and began routine use in infants and young children. And we saw this remarkable change. In blue, you can see that the strains of pneumococcus that were in that 7 type vaccine have virtually been eliminated. But you actually see in the purple other strains, what are called PCV6 here, start to increase. And that's evolution. That's the microbes getting smarter than us. There was some genetic switching and so forth going on, or capsular switching going on, and we have strains that weren't a problem before that turn out to be a problem. But fortunately, we have a new vaccine licensed in 2010 that tackles those additional strains. So these vaccines have had enormous impact in routine use here in the US. But they've also had impact beyond health. They have reduced premature deaths and saved illnesses, prevented illnesses, but they also, in the childhood series, have saved money. So for each year of babies vaccinated through age 6, society saves about $10 for every dollar that we put in, or we're saving about $69 billion total. Enormous impact. But the story of vaccines is not so simple. Some of us feel like they're magic, but we have to always be examining chinks in the armor and making sure that they are living up to their potential. And so a strong commitment to evaluate the evidence for vaccines is critical. We think about smoking guns as the ultimate proof. And when I was here at Swarthmore in studying philosophy, we spent a lot of time trying to figure out what is persuasive, what is a convincing argument, what kind of facts or information do you need to be certain of the truth? And with vaccines, we've been on something of a slippery slope in recent times. There's a certain amount of information that we get when we're studying a vaccine. And again, looking back to the polio story, I find it fairly extraordinary that there was actually a major debate when the polio vaccine was first became available for a field trial. The funders of the trial did not want there to be a control group. They thought, this is a terrible disease, the vaccine seems promising from a few people that have gotten it, shouldn't we just give it to children and see what happens? But Tommy Francis at the University of Michigan, who led the field trial, insisted that a controlled trial be done. And 1.8 million elementary school children participated in this national medical experiment. Over 400,000 received the Salk vaccine, and over about 200,000 received a placebo fake injection, while 1.2 million were just followed without actually getting either product. And the results were compelling. The vaccine significantly protected against paralysis and even death. Another extraordinary feature of this study, besides its scope and the idea that parents, just imagine today, elementary school parents agreeing to have their children sign on for a medical experiment of an investigational vaccine. But another feature of this trial that was really unusual, on April 12, 1955, in Ann Arbor, Michigan, the results of this trial were described live over radio. They were basically broadcast around the country as they were revealed to the scientific community. And a huge national celebration occurred. That same afternoon, in a small hotel room in Michigan, a committee reviewed paperwork from 5 different companies that were applying to license their polio vaccines and really tackle this problem. And that afternoon, with just a couple hours of looking at paperwork, the vaccine was licensed. That same night, the vaccines began to be shipped all around the country. So April 12th, 1955 was this incredible day. It turns out also to have been 10 years to the day after the death of President Roosevelt. So it was just this incredible national celebration. I learned recently that there's another story about this particular week in history. Initially, the Secretary of Health, Education, and Welfare, Olveda Kalpahabi, had thought, well, the market can take care of it. You know, the companies are making the vaccine, they can ship it out, and the market will figure out, you know, to get the vaccine to the children that need it. There was a major uproar. And initially, there was a plan. The government said, well, okay, maybe that's not such a great idea. And the government proposed to make the vaccine available to poor children, and the market could take care of everyone else. And then a representative in Congress held a hearing and said, in America, no family should have to declare themselves poor to be able to protect their children from polio. And the government responded and said everyone can get the polio vaccine, and they made an appropriation and things followed. And so some people say that this polio story was really the beginning of social justice meeting vaccines, that this vaccine was going to be shared broadly and the dignity of families could be respected. April 12th, 1955. Incredible for vaccines, incredible for immunization, for science, for America. It was just a really exciting point, even though I was not born yet. In any case, the people involved with this did not even have a 2-week honeymoon, because 12 days after the vaccines began to be shipped, a public health regional officer in Chicago reported a 1-year-old was paralyzed only 8 days after being vaccinated. Well, maybe that's chance. The vaccine's not 100% protective. The next day, 2 more reports from California. Boys who were paralyzed a week after being vaccinated. 6 more cases within the same day. Polio usually paralyzes the lower extremities. These children were paralyzed in the upper extremity, the same side that they were vaccinated in. What was going on? In, I think, a really extraordinarily efficient feat of government decision-making, by April 27th, the U.S. equivalent of the FDA at the time asked one of the manufacturers, Cutter Labs, to recall its vaccine. Lots of discussion about, should we stop the one vaccine? Should we stop all the vaccines? Should we keep vaccinating because it's only a few cases? But this is really one of the most extraordinarily horrible vaccine incidents in world history. The Salk polio vaccine is an inactivated viral vaccine. The virus is killed through formaldehyde treatment. And what happened was that 2 lots of the Cutter Laboratories polio vaccine were incompletely inactivated. So children were vaccinated with live virulent polio virus. It was horrible. You know, more than 50 children were paralyzed, several died, and polio is contagious. So when a child gets polio, whether it's natural or from an accident like this vaccine, they can spread it. And so some of their siblings and parents and other close contacts also were paralyzed. So that's the horror of this. There's a few silver linings. The very quick epidemiologic investigation narrowed down the problem primarily to this one company. And the legacy is that we've gotten much stricter about how vaccines can be produced and how to regulate them, and really try to have something like this never happen again. For CDC, there was another legacy. The Epidemic Intelligence Service that I was part of, and that was actually started in 1951, was having its annual conference on April 24th when this first couple cases were recognized. The EIS officers were dispatched back. The conference was stopped. The officers went back to their states, and they were part of that quick information gathering that helped us understand what was going on and how to prevent this from happening again. And so the EIS service sort of showed its value and continued to be supported. I want to talk a little bit about evidence and vaccines, and this is relevant for all kinds of scientific questions, whether it's climate change or which foods cause which kinds of problems. Evidence is a tricky thing. With vaccines, we can think about the type of information or evidence we get before a vaccine is licensed, and the type of information that becomes available once we license and broadly use a vaccine. Before we license a product, we have relatively limited information. We can study local reactions, immune response, the clinical protection in a pretty artificial circumstance. People who are healthy enough to be in one of these studies compared with other people. We tend to use randomized controlled designs that can make it cleaner to differentiate the information in the study. But only thousands or at most tens of thousands of people will be involved. Post-licensure, we can understand the effects of a vaccine in many much larger populations. We can use surveillance and understand health impacts, look at the laboratory strains that are identified. We can look at effectiveness in the short term and also the length of protection we get. And we can also look at side effects or adverse events and understand the rare ones that aren't going to show up in a study that's only 10,000 people. But more and more in this century, personal experience and anecdote have become compelling information to convince people about how to think about vaccines. Of course, with the internet and social media, a single episode can have enormous amplification. What kind of information have we gotten in the past decade about vaccines after they go into larger scale use? Well, this slide shows the impact that same pneumococcal vaccine I was talking about had on adults. You can see in the year 2000, the vaccine was introduced, and about a 97% reduction in disease in people over 65. Extraordinary result, because most of the time vaccines don't work very well in people over 65. The most extraordinary part of this story is that the people over 65 were not actually immunized. This effect occurred completely because the babies and toddlers were vaccinated, the strains stopped circulating, and there was indirect protection of the elderly. What I like to say about this, though, is that we almost didn't know it happened. There was no sense that this was going to happen at the time the vaccine was licensed. And in most countries around the world, there's no system to detect that this has happened. You actually need to plan to collect information and characterize strains in a laboratory and figure out what's going on. We almost missed this. This effect was so large, and disease is so bad in adults, particularly the elderly, that the cost effectiveness of this vaccine became much more favorable for a number of countries. And now we're seeing adoption of this vaccine for children in countries all around the world, including the poorest countries in the world. Another incredible recent vaccine story is the rotavirus vaccination story. These data from Mexico show that rotavirus vaccine initiated in May 2007 didn't just decrease rotavirus gastroenteritis, but it decreased deaths from diarrhea among children in Mexico, a really major impact on a bad disease. Diarrheal deaths are the second leading infectious cause of death in children around the world, and the rotavirus vaccine is going into more countries every year. So with these extraordinary stories of vaccines and their impact in the past few years, I found it somewhat disappointing that the first time the cover of Time magazine talked about vaccines in the era when I was director of our immunization program was about this, the truth about vaccines, why some parents are opting out and putting everyone else at risk. The magazine feature was really prompted by a resurgence in measles that was occurring in 2008, and it was discovered that the people who were getting measles weren't children who had missed their vaccinations, the system was failing them. They were people whose parents had refused the vaccine, who didn't really want it. So what was going on? Well, there is a lot of concern out there stemming back to 1998 about the question of autism and vaccines. Of course, autism is a terrible condition, a real challenge for families, for communities, schools, and society. And it's been one that's really been challenging to understand. It's probably multifactorial. But in 1998, a theory was proposed that the MMR, measles, mumps, rubella vaccine, might play a role in autism. This caused a lot of decrease in measles vaccination in Europe, but a pretty consistent use here in the US, until more recently, when we've seen certain communities with less and less use of the vaccine. But a number of studies have addressed this hypothesis, and there's really no causal link that's been found. A number of groups have reviewed the evidence, and in fact, this past year, the Institute of Medicine issued their third report on the topic, really saying there's not a link here. If that weren't enough, in 2011, a British investigative reporter uncovered the fact that the initial paper that was proposed this hypothesis had fraudulent data in it. Dates and exposures were changed. And so a reasonable hypothesis, I think, to wonder about, but the whole thing started from what was essentially a fraudulent article. But a very difficult challenge. Getting rid of a rumor is a difficult thing. So I want to just make a couple take-home messages about vaccines and autism, because I know there's a lot of interest in that in the general population. What can we say about that? Well, vaccination is the best way to protect children from 16 vaccine-preventable diseases. And science doesn't support a relationship between vaccines and autism. But science and scientific communications aren't sufficient to address current concerns. So I want to lighten up a little bit and move to the flying pigs portion of the talk. I have to say I really like the poster for this, and whoever designed that flying pig is very, very talented. You know, flying pigs are a thing that never happens. You know, when pigs fly, that's never going to happen. I found it kind of surprising how much clip art there is about something that never happens. But one of the really neat things about being a public spokesperson is the chance to interact with the public. And during the H1N1 influenza pandemic, the swine flu pandemic, I was one of the people who did a lot of the outreach. And one day, I received a box in the mail that contained this incredible diorama. This gentleman in California is retired, and his retirement hobby is essentially making art pieces about current topics. And I got this great letter from him saying he'd made things for, you know, Arnold Schwarzenegger and Judge Judy, and now I was getting one, so it was really exciting. But in the back, it says swine flu, F-L-E-W, and the little pig with wings is, he's on a syringe, and you can't see it in the photo, but the syringe says H1N1 on it. And it's just a reminder to me that as in public health, it's all about the public and reaching those people, and it's really great when you can have a two-way dialogue with them. So I know that in any group I talk to, there are a lot of different assumptions about preparedness and whether we should be investing in this as a society or whether it's a complete waste of money. So personally, even in my own public health career, I have to say that I have sometimes thought it was a waste of money. I've sometimes thought it was a wise investment, and I've sometimes thought it was someone else's problem. Of course, when I had to become a spokesperson on it, it was better that I hadn't really thought it was someone else's problem too much. But at this point, as an immunization leader, I want to say that I think preparedness is intrinsically linked to our ability to protect people through advances in vaccines and immunization. And so much that I learned in preparing for a pandemic and then dealing with one helps in the day-to-day work of trying to protect populations through vaccines. And the strength of our preparedness system is our ability to use it every day and to not have a completely separate system from the routine systems that we need. But I want to talk a little bit about emergencies and maybe start with that movie. So I'm not sure how many in the audience have gotten to see Contagion so far. Probably not too anybody? Okay, so there's a few. So I'm not going to spoil the story for everybody else. I did get to meet Kate Winslet, and she's pretty scruffy in the movie because of what I told her about us, so no glamour in her job at all. In any case, when you see this movie, it's pretty easy to conclude that it's completely over the top, that this is just unbelievable. But in fact, truth is often stranger than fiction. The figure on the top right shows a little bit of a social network, essentially, from SARS, the severe acute respiratory syndrome, the new coronavirus that spread around the world in 2003. The big circle in the middle is the Metropole Hotel in Hong Kong. There were people who stayed there over 2 different nights, essentially on one floor in that hotel, that had nothing to do with each other, but they were in the same hotel at the same time. And each of the colors represents a different country. And so these people who were just together at a hotel, like a lot of you might be together at a hotel tonight, went back to their countries, and if they were unfortunate enough to be a super spreader, they spread this virus in their own communities. And we were very lucky in the US that the people who came back from the hotel to the US weren't super spreaders. But in Toronto, they had a super spreader, and they had a very severe 2-wave of severe acute respiratory syndrome that summer. Now, you might think in the movie there's kind of a plot line about not enough drugs and not enough vaccines, and you might think, well, that's just over the top. But just about 7 years ago, this week, on a single day, we found out that 50% of the US flu vaccine supply was not going to realize. And there was just all kinds of human behavior that emerged in this era of shortage. We had new recommendations for who was a priority person, who wasn't. My own mother scored her flu vaccine from a friend of a friend in their apartment. You know, it was an odd time. But you know, based on the vaccine capacity being so limited, and also based on the 2003 reemergence of an H5N1 bird flu strain that was killing 2/3 of the people that got it, the government, the US government and governments around the world actually started to take preparing for a pandemic seriously. Our US government started to invest in improving manufacturing capacity so that we'd have more vaccine in a real emergency. There were investments in state and local health department capacity to respond. We had investments in research, investments in new detection methods, investments in better vaccines, which are still going on. We were lucky that we were investing in diagnostic methods. There was San Diego Medical Research Center, the Naval Medical Research Center, was testing a new diagnostic method with some CDC funding. And their first batch of 25 runs of this test, they found 2 results that didn't make any sense. They thought, well, this is a crummy test, it's going nowhere. It turned out those 2 results were right, and it was a novel, untypable flu strain. And as it got to the reference labs, it was understood that with genetic sequencing and such, that this was a totally new influenza strain that humans had never had before. Well, it was just 2 cases. They didn't have any direct animal contact, which we sometimes see, and we didn't really know what to make of it, but we put the report out in the Morbidity and Mortality Weekly Report. And we asked doctors and laboratories to look for it. Well, by 2 days later, on Thursday, April 23rd, we found out about 5 more cases, and so we held a press conference. It was the most unusual press conference I've ever been part of. Half of the questions I got from the reporters were about, why are you holding this press conference? The other half of the questions were, is this the end of the world? I didn't really know the answer, which was typical of the press conferences that I had. But that night we learned that the very same strain with the same sequences was associated with deaths that were occurring in Mexico. And the next day we knew that a school in New York City had an awful lot of illness that seemed likely to be this very same virus. There was enormous media interest in this, and I learned how important it is to have a science voice and a communication angle on how to talk about crises. We get trained in risk communication at CDC and how to communicate uncertainty, how to try to help get through to people when they're really concerned. And it's a very good way to talk to people about vaccines, because when it's your children, you're basically concerned, and you don't need a national pandemic or a global pandemic to have concerns. But the media attention was really extraordinary. One of the major parts of the flu response was a national voluntary vaccination campaign. And as I traveled around the country and met with people who helped put on the vaccination efforts, it was really a moving experience. I met a public health nurse in Colorado who told me about arriving at the football field at about 5:30 in the morning to help set up before the clinic opened around 8:30, I believe. And she got there and she saw that there were mobs of people already there at 5:30 in the morning on a cold Colorado morning. And she realized that she was what we call the incident commander, the person in charge of the program. The person, that term comes from forest fires, so it's sort of how we respond to emergencies. And she looked out there and she sort of took a moment, kind of collected herself, and realized, I can do this, and my people can do this. And they got together and they organized things, and they had a very successful vaccination effort. So preparing for emergencies can help you have the confidence to respond to them when they come, and can really help you get through a lot of other things. I have to say, it was also gratifying that the days where people line up for vaccines are not just limited to the black and white photo era. So I want to kind of turn now to the idea of sitting ducks. And so flying pigs never happen, but sitting ducks, unfortunately, is the state of play right now. You know, the sitting ducks don't know what's coming. They're really comfortable and not really thinking of what is right around the corner or the threats that exist. We're really victims of our own success right now with vaccine-preventable diseases. Our vaccines are very effective, and lots of people, lots of parents, lots of pediatricians, lots of grandparents in the United States have never seen the diseases that the vaccines prevent. So immunization is really real to us. We have firsthand experience, we get vaccinated or we get our kids vaccinated, and it's emotional. But disease is just very abstract and far away. Unfortunately, the diseases that vaccines prevent against, except for smallpox, are not gone, and they're just really a plane ride away. So how do we manage the reality of immunizations and our concerns about them with sustaining concern and commitment to protect communities against diseases? In 2008, we got a wake-up call during that measles resurgence when clusters of measles were occurring in a few different parts of the country. San Diego was one of the epicenters of that response. And what you can see, we found there was a family that traveled to Switzerland. Their 7-year-old didn't just bring chocolates back, but he brought measles back. And he returned to his school where a lot of people were not vaccinated. The slide shows dots that are the proportion of kindergartners in a school that have exempted from vaccines because of a personal belief. And you can see a lot of schools where 1 out of 5 children wasn't vaccinated against measles. And that's exactly the kind of environment where measles can easily spread. So this was a wake-up call to us. We wondered, wow, are we on the edge of a massive national problem? Or is this just, in a few pockets and we can handle it? We were able to respond effectively in San Diego and in Washington State and in Wisconsin to their outbreaks, but we really wondered, how big is the problem? Well, fortunately, our national immunization data suggest very reassuring trends that nearly all parents are vaccinating their babies against nearly all diseases, and measles vaccination remains over 90%. The dip here in blue is actually the Haemophilus influenza B vaccine, and it's not because parents stopped vaccinated, it's because one of the 2 companies couldn't make the vaccine for a while. So less than 1% of parents have toddlers who have received 0 vaccines. So we think, in general, we're not in bad shape. We're really doing all right, but we can't be complacent. And this is what's been going on in the Americas. This is the data for North, Central, and South America collected from PAHO. And you can see that 2011 has been a bad year. In gray is Canada. So PAHO is very worried that the Americas have eliminated measles from our continents, but Canada is having a really big outbreak this year. They've had about 900 cases so far, and the cases are in Quebec. Why is Canada having an outbreak in Quebec? Because France is having an outbreak. In France, they were like us. They would have about 40 cases of measles a year. In 2011, they've had 14,000 cases. It's okay to be able to stop spread when you have dozens of cases in a country, but 14,000, it takes an enormous response. And so you can really go from excellent elimination status to really dangerous levels of disease. Now, about 6 children in France have died from this this past year. But measles in the developed world is generally, it can be serious. You can have pneumonia and be hospitalized, but it's not as life-threatening as it is in poorer countries, especially in the presence of malnutrition. And so we've been working with partners around the world to really try to reduce measles deaths worldwide. There's an extraordinary partnership called the Measles Initiative, which pledged to work together to reduce worldwide deaths from measles by 90% by the year 2010. And they've had extraordinary results. This is led by the American Red Cross, and CDC is part of the initiative. And you can see that by 2008, there was a 78% reduction in deaths from measles around the world. And in Africa, there was a 92% reduction. These are just hundreds of thousands of fewer children dying from measles. In the past decade, we think there have been 12.7 million fewer deaths from measles because of intensified effort to vaccinate against this disease. But we can't be complacent about our programs because you can't just give vaccines once when new babies are born every day. And unfortunately, in Africa, there's been a resurgence of measles. The 2008 was the best year, and the case counts have increased fourfold since then. Primarily, some large outbreaks have contributed to that, and unfortunately, this year, the Horn of Africa has been suffering such a horrible drought, lots of malnutrition, and large outbreaks with a lot of deaths from measles. So we can't be complacent about our programs, particularly in the most vulnerable parts of the world. But we can't be complacent about our programs here in the US either. And speaking to a young audience of college-age kids and parents, I want to remind you about our teen vaccination program here in the US. We've since 2005, have had 3 new vaccines recommended to be routinely given to teenagers. A whooping cough booster vaccine called Tdap, a meningitis vaccine, and the HPV vaccine that protects girls against future cervical cancers. Well, the Tdap and meningitis vaccines are seeing a very nice uptake, but we're doing a terrible job with the HPV vaccine. You can see this gap in coverage is growing. HPV is the vaccine in pink. And the solid bar is the first dose, but you need 3 doses, and that's really doing terribly as well. And so this is a wake-up call that we've really got to get out and have providers, doctors and nurses, know the facts about the vaccine, its strong safety record, and when you're supposed to give it, which is before sexual activity occurs, not way after the fact. And we need to get the word out to parents as well who've had some kind of a sense that we can wait and there's no rush involved. So this is really a big challenge for us here in the US, and I think one that we're hoping to be able to turn around. So it kind of gets at that idea that you can be complacent about your program, you can be complacent about the risks around the corner. And it reminds me about how hard it is to make the case for prevention, because when we are the most successful, we are the least visible. And so I have a lot of thoughts about what we need to do with that, and I just want to start to wrap up here with a few general comments that I think vaccines and immunizations are among the greatest scientific and human achievements ever, but we need an ongoing commitment to gather, analyze, and act based on strong scientific evidence. We need to be prepared for the unexpected, and doing so can make us stronger as individuals and also as a system. But we have to pay attention to sustain the public's commitment and the public's trust in our system. We can't assume that the public will always trust us, and we really have to work hard to earn that trust. So as I think about how can we make this story real to people, I actually think about Andy Warhol, and I say, you know, he managed to take Marilyn Monroe, who was obviously memorable, and find a way to make her unforgettable. And I think with these diseases that we don't see every day, that aren't around us, that we're losing memory of, we have to do the same thing. We have to find a way to take the memorable and make it unforgettable. And I think the next generation of Swarthmore students is probably the ones who are going to help us figure out how to do that. So thank you so much for your attention. So now I will be happy to take questions about what Kate Winslet is really like. Okay, right there? Sure, yeah. In fact, this very week, on Tuesday, our Advisory Committee on Immunization Practices at CDC is meeting, and one of the votes they're having is about a routine recommendation for boys. There are kind of two general reasons that boys can benefit from HPV vaccine. We know that the vaccine protects against HPV virus infection, and boys and girls get that. And they often get it in the teen or young adult years. Boys can be protected against genital warts, and they can also be protected against various types of cancer. But another benefit of vaccinating boys is that you can reduce transmission to girls. And right now our coverage is so bad that it turns out to actually be more cost effective to add boys to the recommendation. So the committee will be voting on that, primarily for the direct benefit to boys. We've already made a permissive recommendation, but we've also already included it in our Vaccines for Children program, which provides free vaccines to uninsured children. A lot of insurance companies are covering it for boys, but if the committee makes that vote, probably all of them will have to. That's right. Yeah, well, there are a couple different kinds of cancers that there's mounting evidence about the role that HPV, the human papillomavirus, has in a variety of cancers. Cervical cancer, genital cancer, anal cancer, and then these special oropharyngeal cancers. And that's one type of cancer that's going up. So there are about 5,000 oropharyngeal cancers in men every year, and it's going up, whereas fortunately the rate of cervical cancer is going down. So we're at a very interesting convergence point, and one of the big challenges with HPV vaccine is we're vaccinating now to protect for decades. So when we got that result that, our vaccination coverage is plateauing, it's like an emergency, but it's hard to make people realize it's an emergency because it'll be evident 25 years from now when we don't have a further drop in cancer rates. The committee is really leaning towards it, so I think it's likely to go that way. But of course, what happens is the committee makes a vote, and then the vote comes to CDC and the Department of HHS, and then there's an additional step. But there's been a lot of evidence in the past couple years since the original licensure that added boys. Now there's more data on cancer, which is pretty compelling. The malaria results are really exciting, and I think they're the first part of a bigger study that will, in about 2 years, give us the answer for the youngest babies. But it's really encouraging because it's the first time a parasitic vaccine has had significant protection, and it's a major killer around the world. I would say that compared to when I started at CDC in 1988, things are just so much better for vaccines and global needs, that the ability for the global community, for countries who need it, to mobilize public-private partnerships to get products developed for people who need them, even if they don't live in rich countries, has really been transformed. I mean, when I came to CDC, I started working on a meningitis problem, West Africa, and actually there's a belt in Africa with recurrent terrible epidemics of meningitis that, don't happen here. We get vaccinated if we're traveling there, but, there wasn't a solution for that belt in the country. But the Gates Foundation put $70 million into a public-private partnership, and the Serum Institute of India is making a vaccine now that works well, and 20 million Africans have already been vaccinated, and the first season results were phenomenal. So there's sort of global support for that kind of thing, and I do believe the malaria vaccines will be taken up in the same kind of way. Yeah, absolutely. Vaccine shortages are very complex, and a lot of people feel like the drug companies are just making too much money. They should lower the price. We should all have access to these products. But in the 90s, the vaccine companies sort of were getting out of the business because they didn't have a viable business market. They were not making enough of a profit to kind of modernize their factories. And we got into a number of shortages. And so there's this sort of balance, what we call vaccine security, that affects vaccine supply, that there needs to be some sort of business model that gives enough cushion that we have a supply, and those companies just don't move to the drug market, which is often more lucrative. So in the 90s, the prices that companies could charge for vaccines were no longer capped, and when they had a new vaccine, they could charge more for it, like a lot more. But they also had some commitments around supply. And then we also got, in 1994, this bill that made our Vaccines for Children program for uninsured children also created a stockpile, so that we were able to have resources to be able to buy enough vaccine for 50% of the pediatric population, to sort of give the companies incentive to make more vaccines, so that when we ran out of that Hib vaccine in 2007, we actually were able to redirect our stockpile to the highest risk areas. So it's a business economic thing that you have to have enough in the system to keep the companies in the system. Long time ago, governments produced vaccines, but these days it's very much a private system, but with a little bit more government investment and incentives. Yeah, so measles is the most contagious infectious disease, or one of the most contagious infectious diseases, and you need very high coverage, and it actually requires 2 doses. We vaccinate babies at 12 months and then again at kindergarten entry. It needs a pretty high population protection, and when you start to kind of not vaccinate in a community, everybody, and the strain comes in because it's still all over the world, everyone who's not vaccinated is going to get it. I mean, the thing with measles, for the older people, they may remember this, that you can bring a child with measles into a doctor's office there and then have them leave, and then bring another child in 4 hours later, and they can get measles, just because it's airborne and it sticks around for 4 hours. So the pediatricians used to have a separate door and separate times when the people with measles came in, and we had a horrible problem in the 89 to 91 with outbreaks in emergency departments where kids were coming in with broken arms and left with measles, and you can spread it before you have any symptoms. And so, they had enough vaccine refusers that it was able to gain hold. There's been big outbreaks in Switzerland, also in a couple other places in Europe. And in fact, there's an effort right now to try to build a case for eradication of measles. And we think we could do it in Africa and Asia, but we don't think we could do it in Europe because of some of the attitudes there. So it's a tricky issue. With anthrax, we have a lot of anniversaries this month. This is 10 years since the initial bioterrorist anthrax attacks, and that really diverted a lot of public health effort. But the anthrax vaccine that's available right now requires a lot of doses. And you may recall there were issues that the military were required to get it, and then they refused because of the side effects. And since that happened, we've been able to show that giving it by a different route of injection gives less side effects, and that you don't need quite as many doses. But you still need a lot of doses. And so there's been research investments to try to make a different kind of anthrax vaccine. And those initially were very disappointing. There were sort of a lot of money went into it, and it didn't produce the results that were hoped for. I'd say the government's rethinking the investment strategy for vaccines against these very rare conditions that can be catastrophic, but can, of course, not happen year to year. And so instead of necessarily focusing on one agent and product, they're trying to invest in more multi-use approaches, research that will lead to a lot of different technologies, and also research on the regulatory science that will give us a pathway to license products that doesn't reduce the safety problems, but also addresses the need for some of these things to be developed, in a reasonable set of steps. Yeah, the question is about what's our strategy for monitoring infections that can be asymptomatic. Chronic hepatitis B can lead to liver failure, cirrhosis, and it can lead to liver cancer. And it can be silent for decades. There's a universal screening in pregnancy that we make sure that women get screened for hepatitis B, that silent state, because they can pass it on to their babies, and there's ways to prevent that from happening now. But we don't really have a national, everybody has to be screened against hepatitis B. So you get at a really interesting point about how do we track diseases that have an acute phase and a latent phase or a long-term phase. And it actually goes back to AIDS as well. Like, how did we know what was going on with AIDS? It turned out, people were infected decades before they showed up with illness. With hepatitis B, there are a couple different approaches that the CDC uses in sentinel counties or in special areas where extra stuff can be done. Some are looking at the liver disease episodes and then making sure there's tests and going back. Some are national sero surveys that there's something called NHANES, the National Health and Nutrition Examination Survey, where these big vans go around the country and enroll people and collect, all different age groups and clinical specimens on them. And we can track, where we are with the chronic conditions. And then there's interesting mathematical modeling that gets used to sort of say, if we've got this much in the acute and this much of this end stage, and we're doing treatment like this, how do you put it all together? So for the math and engineering students, there's a lot of cool studies you can do in modeling infectious diseases, including that chronic disease piece of it. So thimerosal is a preservative that includes ethyl mercury, and it was in the news a lot in about 1999 when people realized with all these extra vaccines that kids are getting, or the newer vaccines, the amount of ethyl mercury that they were getting, at that time people realized, oh, it's actually more than what the EPA says you're supposed to have. Well, since that time, there's been a lot of research done into what were the long-term effects of the thimerosal-containing vaccines and other products. And there really haven't been any harmful effects at all. And it kind of makes sense because ethyl mercury is quickly metabolized. It's methyl mercury that's in the environment that has a much longer half-life. And with the fishing accidents and so forth, it's the methyl mercury that sometimes has led to acute mercury poisoning. So in the thimerosal situation is that there don't seem to be any health hazards associated with it. That said, there certainly have been consumer concerns about it and a request, well, we don't know if it's a problem or not, why can't you just take it out of the vaccines? It turns out it's easier to say that than to do that, and there are a lot of implications. So in the US, the pediatric vaccines, except for flu vaccine, don't have thimerosal anymore because there were commitments made that said we don't know the effects, but let's just have the industry change their practice. But it's really important to have a preservative in a multi-dose vial because otherwise you'll get bacterial contamination and can get abscesses or pretty bad complications. And so right now the medical community is pretty comfortable that it's not a problem. In the US it's just in some flu vaccines. But it's become a big issue internationally right now because not really thimerosal but mercury, because there's some environmental treaties that are being discussed about trade and products that have mercury in them because the environmental mercury is quite a bit different. So my personal feeling is that it's totally fine to have thimerosal in them, but that was one of those things that the system actually responded to consumer concerns. There's a lot of good things about getting older, and one of the things is that a lot of us my age and older have already had these diseases, so we actually don't need the vaccines. But it turns out that we have recommendations for adults that are based on year of birth. For something like measles, we say if you were born before 1957, the chances are you had measles, and you don't really need the vaccine unless you're a healthcare worker, in which case we want to be absolutely sure that you are protected and you can actually collect a titer. But it's great to bring up adult vaccines because there's a lot of vaccines that didn't exist when you were younger. And so we have a shingles vaccine, zoster vaccine, which is recommended for everybody over 60 to prevent a very common, skin problem that can lead to neurologic terrible pain syndrome. There's also a vaccine against whooping cough, this booster dose Tdap that wasn't even developed until 2005. So very few adults of any age have gotten that vaccine, and we recommend it for adults of any age now if they're going to have close contact with a baby because it's very, very severe in newborns. But you also get at this whole issue of information systems. And CDC's been trying to support health departments developing immunization registries. Unfortunately, when this really started in the 80s and 90s, there was not political will to have a single system and a national identity number. And so every state, except for one, has their own registry. And they can sort of look at each other's records, but there are 49 different systems. A lot of those now are lifespan ones where adult immunization information can be in it, but it's not as well completed. And the big move right now is to connect those registries with the electronic health records so that whoever vaccinated you, the registry will get that information and you'll be able to access it. And the school that you transfer to or the new doctor that you get will have that information. We have a lot of work to do with that. Yeah, it's a huge issue. The culture of pediatrics, pediatricians, especially those over a certain age, their lives were transformed by vaccines because all of their business or all of their practice was taking care of these diseases because they were so common. And the vaccines became what they do now. They give out vaccines and those diseases don't happen. But in adult medicine, it's very unusual to even think about vaccines, let alone stock them. One of our strategies right now is to broaden where you can get vaccines because a lot of adults who need vaccines aren't seeing a doctor regularly. We'd like the doctor's office to stock the vaccines and at least make a recommendation for it, but we'd like it to be accessible for adults at the workplace, in the pharmacy, in community centers and settings. And so the key thing for that is to have the insurers cover it. And sometimes the insurance plans will cover vaccines only when you get it from your primary care provider, but if your primary care provider isn't stocking the vaccine, what are you supposed to do? So we're working with the American Health Insurance Plans, or the Association of American Health Insurance Plans, and with the state health departments to really broaden what's considered in-network for vaccines so they can be easily accessible. I know here at Swarthmore they offer the flu vaccine to staff and so forth, and workplace vaccination is a great thing for healthy adults who are never going to get to the doctor's office. So I don't think I'm allowed to answer any more questions. I really want to thank everybody for your interest, and good luck with your work.